Hello, I'm Kerstin Hogg. I work in both emergency medicine and in thrombosis medicine in McMaster in Canada. I did my training in emergency medicine here in Manchester, and then I moved to Canada to learn thrombosis medicine. So my talk today is reviewing the options for treatment of venous thromboembolism in 2015. And I'm sure everybody is aware that the options have changed dramatically over the past 20 years. So the talk focuses first of all on low-risk pulmonary embolism and deep vein thrombosis, the kind of patient who you may well send home for outpatient treatment. Really accounts for about 90% of the patients we see with acute DVT and pulmonary embolism. And our mainstay of treatment for these patients is now either rivaroxaban or apixaban oral anticoagulation, which can be offered from the outset from the emergency department. There are two groups of patients who preferentially should have low molecular weight heparin. They would be patients with active cancer, particularly patients having chemotherapy, and pregnant patients. And then there's one final, very small group of patients who may be diagnosed with acute venous thrombosis, who might actually need intravenous heparin therapy. And those are the patients who are on dialysis or who have severe renal impairment with a creatinine clearance of under 20 to 30 mils per minute. And those patients still need to be admitted to hospital, to be given intravenous heparin and started on warfarin. So as far as treatments for the high-risk pulmonary embolism group goes, we also have seen some exciting changes in that area. And these are the patients who would normally come into the resuscitation room. We would see them as hypotensive, a systolic blood pressure of 90 millimeters of mercury or less, or else with a sustained drop in their blood pressure of at least 40 millimeters of mercury. And the treatment for these patients is very different because it's focused on opening up the pulmonary arteries to allow blood flow so that the heart failure aspect of the acute pulmonary embolism can be treated. And it's important to have planned ahead for these patients. So our options would be the standard thrombolytic agents, either TNK or TPA, which would be associated with a high risk of bleeding, about 10% risk of major bleeding, and a 2% risk of intracranial bleeding. So it comes with a very high risk, and that's why we would suggest you would only use a thrombolytic as somebody who is hypotensive. And then we have two other options, which depends partly on the hospital setup and the links that the emergency department has already made with colleagues in other specialties. So the first would be cardiac surgery with embolectomy of the thrombus from the right and left pulmonary arteries and from the pulmonary trunk. And as you can imagine, that requires significant work in order to get a process that would flow very rapidly from the resuscitation room for that. And then the last area of development is intravascular thrombolysis, which is an emerging therapy, which is conducted by interventional radiologists or else cardiologists and some intensivists. And that involves putting a very tiny pulmonary artery catheter, inserting it right into the blood clot itself in the main pulmonary artery, and infusing a thrombolytic agent like TPA, 1 milligram per hour for 24 hours, with a view to reducing the clot size to allow the blood flow to flow freely through the lungs again. So those are the mainstay treatments today for venous thrombosis in the emergency department. And that really covers the talk that I'll give today.